Good afternoon, everyone. And at the outset, I would like to thank Dr. Kim and David for giving me this opportunity to share my experience on primary vitrectomy as a modality for rheumatogenic retinal detachment. I have no financial interest in the procedures or the material that is being talked about in this presentation. Whenever you think about rheumatogenic retinal detachment, there are various surgical options that are available. We should not forget about delimiting laser as a modality for a localized retinal detachment, which can successfully be observed after delimiting laser. We have at least have the experience of limiting it for years. Pneumoretinopexy and scleral buckle are already been used in selective cases, and they have their specific indications. Pars plana vitrectomy alone, standalone, is gaining more popularity with the advances in vitreoretinal surgical instrumentation as well as the machines. However, combined pars plana vitrectomy, it means with belt buckle and vitrectomy, has its own specific roles. So I will be dealing mainly with pars plana vitrectomy. However, I will be touching upon other procedures during the course of the presentation. In this august audience, I want to stress that the duration of retinal detachment is the key for successful visual outcomes when you are intervening. So I would request all of you to refer if you cannot manage or intervene at the earliest to have the best results. A simple case like this with a single break, even if it is superior or inferior, a scleral buckle can be successfully done and the patient can remain stable without disturbing the vitreous milieu. However, as the retinal break increases in size, it becomes more difficult for us to only handle with scleral buckle. So here the vitrectomy will be playing a major role. Inferior chronic break. My preferred modality is scleral buckle, though I am dealing with vitrectomy as a primary modality. This is the case exemplifies that vitrectomy is the only choice here, not scleral buckle. And if you see the posterior location, a large break and an active traction, all three will suggest that vitrectomy can be the primary modality. Giant retinal tears, it will be dealt with later, but definitely an indication for vitrectomy rather than scleral buckle. If you are going for a belt buckle in giant retinal tear, you should not tighten it too much, because the indentation itself will worsen the slippage. Though the perfluorocarbons, they always take care of the slippage, should be used along with the vitrectomy. Advanced stages of PVR, always an indication for vitrectomy rather than scleral buckle. And a recurrent retinal detachment, it's a clear-cut indication for primary vitrectomy rather than a scleral buckle. So I enumerated all the cases which make you think that these are the cases for vitrectomy rather than buckle. However, certain cases will they are the primary cases. There is no choice than vitrectomy. Those are macular hole associated detachments, rheumatogenic detachments with no PVR, especially in the superior breaks, uncomplicated recurrent retinal detachment, and traction whenever is present, or the media opacifications. Combined detachment procedures like pars plana vitrectomy as well as belt buckle, this has a set of indications where advanced stages of PVR, giant retinal tear, choroid coloboma, traumatic cardi, these to be dealt with always give support for the tractional element so that it will be having a long-standing good results. There are several reports, comparisons, but to a given clinical setting, no two cases of fragmentogenous detachment are similar. So the results, certain times you have to take it with pinch of salt. Here there is a meta-analysis which found that very few studies are really randomized. Out of that, they are not finding a good different results with in a simple case of fragmentogenous detachment, whether buccal is superior or pars plana vitrectomy. However, what I found is that a better visual acuity is good with vitrectomy. This is mainly because of this fact that the disappearance of subretinal fluid is much faster with vitrectomy rather than scleral buccal. Recurrent detachments, when you see the results, it is always when, in this study at least, shows that buccal as a primary surgery, the results are better. This is because the vitrectomy has happened and there is a recurrence. The worsening of detachment is very fast once in the post-vitrectomy phase. That's why the results after vitrectomy probably are worse compared to a planned approach of primary buccal, and then if there is a failure, then vitrectomy. However, failures are much more with buccal than with vitrectomy. I would like to conclude my talk of primary vitrectomy and fragmentogenous retinal detachment as PPV more preferred now fragmentogenous retinal detachment, except for the complex detachments where you may have to add up the additional support with belt. Scleral buccal is a preferred modality for a simple detachment with inferior break, because there, if you are using oil, the support may not be that great. Always use PFCL in complex cases like giant retinal tear, and current rates with the tailored approach is almost approaching 100%. So you need to plan whether you are going to succeed at the first place in 100% or not. Otherwise, plan the second surgery in the first surgery itself, so that initial part is taken care, and while going second time, it will be much more easy for you to tackle the detachment. Thank you for your attention.